I'd like to ask my co-speakers for this session to come up and have a seat on the podium. I'm not quite sure where the microphones are. There you are. Okay, perfect. So if anybody has a question, please, in order for it to be heard by the whole room, please use the microphones. I wonder if I can quickly kick off with a question to Mark regarding surgery. One of the observations that's been made around the transplant program has been the percentage of patients, which you talked about, that had no disease at all. And so the question is whether they did have malignancy in the first place, because they were not all able to have histological or cytological confirmation. And the converse of that question is to Joe. Do we believe in a path CR rate? And does intensifying our treatments actually lead us to a pathological complete response? Mark.
So should I start? You're not talking about the patients that we transplanted with intrahepatic, because these are big. At least in our program, most of the patients that came to transplant had massive disease.
Yeah, it's a higher.
Now, in the Mayo experience, I can't remember, about 30% or 40% of patients, there was no evidence of disease. And, as you know, cholangiocarcinoma is not a, oncologist, they're very persistent on finding the cells and doing all this. But anybody who presents on a radiological finding of narrowing, it is a Klatskin's tumor until proved otherwise. And a lot of people who go for a resection actually go on radiological findings, and 90% of those will end up by having cancer. So the question here is, you may have had people who did not really have cancer, but you also may have had people who responded to treatment. When you're looking into all the results that you give, you try this protocol, that protocol, there's about 20 or 30% of patients who are going to respond all the time. And we've not been able to figure out who would not. So my guess is these are other people who responded, and probably there's maybe a few who may not have had a malignant stricture to start with.
And I think a compliment to that, I agree with the comments. I think that it is tough. I think we're in an era where we're relying on the imaging that we have available to us, and many of these patients present with a stent already, which makes it very difficult to ascertain, is there a mass there, how much of a mass, or is it fibrosis from the intervention itself? But I think that at least when you look at the Mayo protocol and the data up to this point, for Hyler specifically, the smaller tumors, it kind of makes sense that when we're giving around 50 gray with external beam and then we're doing brachytherapy on top of that, it makes sense that we probably are sterilizing a proportion of these very small tumors with what we're giving. And then also I think genetically, there are probably a subgroup of patients that just tend to respond. And I think you see this a lot in general, that the patients who respond to chemo, for example, tend to also respond to radiation and tend to also probably not recur. So I think there's an inherent biology that we still need to better understand. And eventually, if you kind of combine each of our presentations, it kind of brings to light some of the issues of larger tumors become more of an issue, more poorly differentiated tumors, and then also satellite, when you're dealing with intrahepatic. So I think ultimately we can get smarter, be even more selective, and I think even working with our sort of translational genetics, but also modeling. I think there's really, in the same way that we're getting smarter in how we're developing our trials, I think that working with our statisticians who are very, very bright and thinking outside of the box and sort of feeding variables in up front, and then taking all that data and helping spit out sort of the best patient for the best modality and the best approach, such as multiple bucket trials or Bayesian approaches. So I think we have a long way to go, and with a disease that has a small number of patients, we have to do more multi-institutional studies and work together to get to a better outcome.
Millind.
I have a question for Sue, and if there's time, for Mark as well. So Sue, you have done really pioneering work, because people with biliary cancer often die of cholangitis and infection, and it's not recognized or not given importance to. So how will you measure the success of your interventions and the education? How will we know that those measures have actually helped?
Well, that's our next phase, Milind, is that putting evidence into practice. The recommendations came from evidence-based research and institutional practice. And as we go forward and we have metrics then with respect to a quality of life questionnaire, perhaps for our patients, that we're thinking of implementing so that we know if indeed these guidelines are being implemented, if we can improve upon them, are we addressing the concerns of the patients? And that's how we started with respect to looking at the patient registry, the concerns and the discussion board, the concerns that patients currently have, what have been the issues that they're facing. And that was the springboard for us to develop these guidelines in the first place. And so then going out at large to the associations and presenting and getting feedback from physicians who attended ASCO. We presented at ASCO Palliative Care Conference in 2015. 2016, the Astro EONS. And what came back to us was that this is very good information. This is what our community needs. And now the process is getting it down to the front lines so that we can measure the effectiveness.
So if I can propose, maybe you could consider a prospective study, apply for funding, such that you can institute that intervention, look at hospitalization rates or some such measure to say that this has truly made an impact. And I personally think it has, because even in smaller centers, cholangitis is not recognized, appreciated, and people die from that rather than from the cancer. If I have a moment, I'd like to ask Mark. So Mark, you're the intrahepatic cholangio transplant. We are excited, but we are invested parties, so we are highly biased about it, of course. There's a lot of patient selection, waiting time, et cetera, could be a year. But how would you propose, and you're using, I don't think I heard that, you're using the extended criteria so that you can get outside the box and use sometimes livers that could not be used for other reasons, other transplantations. How could we get the message out so that this could be done in a larger setting so that, within a real time frame, we would learn if this therapy works?
So yes, there is selection bias, but the Mayo Protocol also has a very strong selection bias. I mean, you're selecting it by size or by laparoscopy, by a lot of other things. But we're trying, what we're trying to do mostly is get away from size to biological activity of the tumor. You have no way with your chemotherapeutic agent of trying to figure out who will not respond from the very beginning. As a matter of fact, you always try that, by looking at biomarkers and, what happens in the progression of the tumor. In our world, I look at progression. We select the patients just by waiting on the list, because it's an effective way of looking at it. What I'm hoping here is that we get to a point where we had a follow-up. 3-year follow-up is very good, and we get to the 5-year follow-up is excellent. Hopefully, we add about 4 or 5 extra patients. Now, once you have 10 patients on, with those criteria, we can move in and say, we can really write a good manuscript and say, in cholangiocarcinomas, you're able to change that. And that may change the attitudes of people as we go down. I think that's one way. Now, I will also tell you that we use extended organs for transplanting those patients, but those patients don't have underlying liver cirrhosis, so they can tolerate 50% fatty liver. They can tolerate a liver with 10 hours cold ischemia. They'll struggle a little bit, but then they'll pick up function and be okay. The third thing I'll tell you, we do about 7,000 transplants a year. Oh, I'm sorry. I don't want to take the time of everybody.
Please go ahead.
So normal criteria, when you say get a donor, anywhere between age up to 55 years of age, when the liver flies from one area to another, you don't want it to be in the ice bucket. You take the liver, you put it in an ice bucket, you take it out, you put it in the patient. So the cold ischemia time should not be more than 6 to 8 hours. The liver should not have a lot of fat in it. Anything outside of that is considered to be extended criteria. So a 75-year-old liver, 80-year-old livers, and livers that have a lot of fat on them, livers that somebody took out and didn't have a patient, they've been sitting in an ice bucket for 12 hours in California somewhere. We bring those and we can use those. So these are extended criteria donors. In the future, hepatitis C is treated. This is a good time to start talking about cholangiocarcinoma. Hepatitis C is treated, which is about 40% of the patients. That may really get a drop in us. So a lot of centers are looking into what else are we going to do. So there is an increase in the percentages of patients transplanted for alcoholic liver disease, for example. There's an increase in the patients who are being transplanted in the fatty liver disease, and very, very high increase in liver cancer, hepatocellular carcinoma. And we may be able to start, thinking, okay, cholangiocarcinoma is an okay thing to do, and that study plus others that we look to do in the future will pave the way for that, I think.
Thank you.
Hi, Shishir Maithal from Emory. I really enjoyed all three presentations, and thank you very much for that. I also just want to say publicly, this is my first time at this meeting, and I've just had a fantastic time, and I've told Stacy this, but being at a meeting with the integration of patients and practitioners is a very novel thing for me, and I've really, really enjoyed it. I had some great conversations with some of the patients, so thank you for all that you have taught us and the inspiration you give us with your stories. So I have excuse the length of my comments here, but I'm going to kind of have some comments and questions, and I'd just like to go distal hilar and intrahepatic. So for distal cholangio, I think, Joe, you just mentioned right now, given the rarity of the disease, the multi-institutional way is definitely needed because no single institution is seeing enough of these. So in that vein, we have assembled a 10-institution biliary malignancy consortium, and we've looked a lot at this, and we focused on hilar gallbladder cancer and distal cholangios in that consortium. So just to look at the distal cholangios, and you made the comment a little bit about chemoradiation being relatively a standard of care after a Whipple. I would just say that I think we need to be careful about extrapolating the data from pancreas cancer to distal cholangio. I mean, we had a poster here that we presented looking exactly at that in our 10-institution consortium, where the adjuvant therapy in the distal cholangio patients actually did not improve their survival. And I would say the radiation question, with all due respect to you, is still a little bit under question for pancreas cancer. So I would just say for distal cholangio, I think it's still out there whether or not chemoradiation or chemotherapy after resection plays a role. I do think the neoadjuvant question or the preoperative question is the key. However, the problem is distinguishing distal cholangio from pancreas cancer preoperatively is almost an impossible task, because right now it's just based on a gross evaluation. And so until we can come up with biomarkers or some things in the bile that can help us distinguish that, it's very difficult. And just from an anatomic standpoint, given the nature of the bile duct and the early onset of jaundice with the distal cholangio, few distal cholangios are borderline resectable with the vein involvement and all that, and so those often, and if you put most of them, just statistically, they'll end up being pancreas cancer in the end. So just my comments on distal cholangio, I think we have to be careful about extrapolating pancreas. From the hilar standpoint,
Can we just get a reply to
oh yeah,
that?
sure.
Yeah, no, I mean, I don't disagree. So I think the point I tried to make is that I think from a multi-institutional study perspective, and I haven't seen your data, so I do apologize, but I think that the key is we don't have great data right now. And so I think it is a standard. If I said the standard, I apologize.
No,
but I think it is a standard, and I think again, patient selection is important. I think I mentioned mainly margin positive is really a strong indicator. So I agree with you. And I think that from a neoadjuvant perspective, I also believe that it really comes down to patient selection. And I think in the same way that we're looking at platinum agents and DNA repair, I also think that if we can select patients who we think will benefit from radiation that have a DNA repair pathway. So again, I think we're on the same page, and it depends on the patient, the size of the tumor, et cetera, et cetera. And I think selecting patients better moving forward makes sense.
Yeah. And then just to move to hilar, I think that I'm a surgical oncologist. I don't do transplants. I do the resections. But I think for hilar, absolutely, for the right indications, transplant is the way to go. We, in that institution...
Can you say that again?
Yeah, no, I've published papers. I have no problem with this. I've published papers on that as a senior author, saying that transplant's the way to go for hilar. And in my own practice, I try to get them all to transplant if they can meet the criteria. In that same institution, in that same multi-institutional collaboration, we actually just did a study looking at the hilar transplant data from WashU, Wisconsin, and Emory. And everyone always looks at the selection bias, and they say you're comparing apples to oranges. So we actually tried to compare the patients who underwent resection, who had sub-3 centimeter tumors, negative margins, and no lymph nodes, and compared them against patients who got transplant, according to your question that you just asked, Juan, with a tissue diagnosis of cholangio, either pre or post-explant. And still, the transplant patients did a lot better. So given the nature of the disease, it's difficult. And it's difficult to give them chemo and chemo XRT post-resection because very few patients after hilar resections recover strong enough and quick enough to get on to that therapy.
That is very important. And then the other thing is, us as transplanters, you never want to be accused that you wasted an organ.
Right.
And every quarter, remember when you look at the stock market, everybody's around our quarter, Google reports by quarter. We have the SRTR, which is Scientific Registry for Transplant Recipients, giving us every quarter an account of our patient survival, our graft survival, our rate of transplantation. Again, there's nothing more transparent. You can find out this information readily on the internet. And if you drop below expected survival for any reason or another, right, You have CMS on top of you, and you have the SRTR on top of you, let alone the CEO and everybody else in the hospital, and their mother and their father are going to be knowing that, and they're going to be held accountable. If you go 2 or 3 and you don't fix it, 2 or 3 quarters, you're going to have CMS investigating you and giving you copies and a lot like this. So there's a lot of pressure on the transplant centers to really come up with expected rates of survivals. So now, if you're going to go and do cholangiocarcinomas, it takes a little courage, because you have to at least meet the threshold of 70% at 3 years. Now, if we provide data, whether it's intrahepatic or hilar, to say that we can transplant this group of patients with a 70% expected survival, this is going to be acceptable, because we don't think that you should use an organ that gives you less than 60%. So the fact now that we can achieve that with intrahepatic and achieve that with hilar, you're going to find a lot of people moving on to transplantation. The second part is the courage of the oncologist to send the patients to transplantation, because that's very foreign for oncologists. You call your surgeon who sits next to you, but you don't call the transplant surgeon who is far away from you. Transplantation, ooh, we got to. When that changes, you're going to find a lot of people getting in there. And your statement that transplantation works better, I mean, I cannot thank you and congratulate you more for that. Coming from a surgeon oncologist, it takes a lot of courage. And no, seriously,
It's not. I mean, for me, it's not about courage. It's what the data is and what the truth is, and that's all. I'm just trying to do the best thing for
it
patients.
is a lot
So
of
if
courage.
it's not in my
and
hands, it's
this
fine.
is a lot
I have
of
no
a lot
problem with that.
of a lot of being invested in the patients and advocacy for the patients, and you should be thanked and congratulated for that.
So, a couple questions about the intrahepatic. Do I have one more minute?
Yep.
Intrigued about the intrahepatic protocol you have. Just a couple questions on that. Are you, in terms of lymph node evaluation for the intrahepatic cholangio protocol that you have, are you employing the same techniques as for the hilar in terms of either preoperative EUS and laparoscopy? 2, what does the background liver have? Is there any consideration of the background liver to these patients with intrahepatic cholangio with a normal liver? Are they still candidates for that, or do they have to have background liver disease? The third thing, I'm assuming these are for only unresectables. And then the fourth thing you mentioned on your multivariate analysis in terms of the predicting the recurrence, you had lymphovascular invasion and perineural invasion, all those factors, which are very difficult to identify preoperatively or on biopsy. So how are you handling?
These are all
really
excellent questions. So the first is the CT scan and MR. The CT scan probably is much useful for us. We don't, by the time they come to us, they come from hepatologists and the ERCPs and all this kind of stuff, and it can be very low yielding. I don't put a lot of credit into it, but the hepatologists would investigate the patients to the halt, so they would have something. I don't look at the CA19-9 because even in the Richard studies and the Mayo criteria, it makes sense, and sometimes it doesn't make sense other times. I don't look at that. Lymph nodes, if you see something, a big lymph node, the ERCPologists are jumping on it. They just want to put needles and get biopsies from it. In reality, you're going to see a lot of reactive lymph nodes around those patients, and you don't know where they came from. We do laparoscopy. This is what I look at. And the laparoscopy will show you that if there's any carcinomatosis on the peritoneum or anything, if you don't find anything of the sort, we're okay to go.
So you're not doing a lymph node dissection at the time of laparoscopy, standard in the protocol?
No. I looked at it in there. When most of our patients that we got them, we don't have it. And then you can find a lymph node. Remember that the initial studies that came out from the Milan criteria, they looked at the lymph node positivity, and it didn't make a difference. When we go in there, we're going to be taking all this out. So unless there is a big lymph node that's outside, I'm not going to bother with it. There's a couple of times that big lymph nodes were biopsied and they were positive, we stopped. But that's not usually something we look to. If you start going into the hilum, dissecting into the hilum, it's on a...
Yeah.
Thank you very much. It sounds like you guys need to sit down
Sorry.
and have a coffee. I'd like to thank my co-panelists, and I'm going to close this particular session. So thank you very much. You're released.
Thank you.